Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for December 7th, 2023. We do not have a CME activity code, but in lieu of that, Dr. Baxi was playing music, which of course now he's turned off that I'm bringing it up. But we're always trying to improve the conference, and this is this is what we're left with now. It's playing music. Steve complained, I like it. So, and Casey gave it a thumbs up. So you're stuck with it, Steve. So. We have a good fun case today. Welcome back, everybody. Before I forget, Hanukkah starts tomorrow. I want to wish everybody happy Hanukkah. We've been off a few weeks. It's good to be back. As usual, we have nothing to disclaim, and the privacy of the patient's totally preserved throughout the case. We've got an interesting case. Dr. Haidt, our first-year fellow, is going to read it, and I'll hand it over to Steve.
Thanks, Dr. Rebbe. So today we have a case of a 34-year-old Black woman who initially presented to Rush when she was at 14 weeks gestation, unfortunately after experiencing a cardiac arrest, secondary to hemorrhagic shock from acute uterine rupture with hemoperitoneum. We got involved with her case. So her serum creatinine on admission was noted to be 1.94 with a GFR of 33. And her UA at the time was noted to have 2+ blood, 2+ protein and 3+ blood by dipstick with 30 RBCs per high power field. She had an XLAP with hysterectomy, self-injectomy, and fetal evacuation. After she had her surgery, she developed acute kidney injury with an elevation in her serum creatinine up to 13.5 milligrams per deciliter, and she was started on renal replacement therapy. She was oliguric and remained dialysis dependent throughout her hospitalization, was ultimately transitioned to outpatient hemodialysis. She did later regain renal function with an improvement in her creatinine to 3.1 milligrams per deciliter at the time of her transition off of hemodialysis, approximately 40 days after she was initially started. Fast forward to about 2 years after her initial hospitalization, she began to endorse fatigue and was also found to have iron deficiency as well, with a saturation of 19% and a hemoglobin of 10.5 grams per deciliter, which was noted to be out of proportion to her chronic kidney disease with an estimated GFR of about 63 mils per minute. She was referred to gastroenterology and hematology as well, specifically after GI deemed that she was not in need of an EGD or a colonoscopy. Through her evaluation with hematology, she did have both an SPEP and a UPEP completed with immunofixation, which were remarkable for the presence of an IgG kappa paraprotein with an elevated capital lambda ratio. In terms of her ROS, she had fatigue, but otherwise her review of systems was negative. In terms of her past medical history, she had a known history of hypertension. She had gestational diabetes, but did not have diabetes at baseline. She did have morbid obesity, which had a BMI of close to 50 over the time that we had been seeing her, including for a few years prior to her initial presentation. She was also of note born 3 months premature and experienced hospitalization for 6 months after she was born. The surgical history is relevant for the laparotomy, as we already discussed, and the self-injectomy, omentectomy, and fetal evacuation. She had a known allergy to ibuprofen and was taking only losartan on a daily basis in terms of her medications, but was also taking acetaminophen, Zofran, and a lidocaine patch as needed. She had no history of smoking, alcohol use, or other drug use, and there was no known family history of kidney disease for her. In terms of her exam, she was normothermic. Blood pressure was 138/78 and a pulse of 82. Respiratory rate was 16. Her weight was 116 kilos with a BMI of 47 at the time of our evaluation. On her actual exam, she was obese. Otherwise, HENT was normal. There was no concerning signs for lymphadenopathy in her neck exam. Breathing was non-labored and cleared auscultation bilaterally. Cardiac exam was within normal limits without presence of a rub. And her abdomen, outside of being obese, was non-tender, and there was no tenderness palpation. She did not have any signs of lower extremity edema. Her skin exam and neurologic exam are both within normal limits. In terms of laboratory data, she had a sodium of 141, potassium of 4.0, chloride was 104, bicarb was 21, BUN was 8, creatinine was 1.0 with the GFR of 72 mils per minute, glucose was 122, calcium was 8.8 with a normal albumin, her alk phos was 81, AST was 18, ALT was 10, bilirubin was 0.2. For her CBC, she had a white count of 6.5, hemoglobin remained at 10.5, platelet count was 285. In the iron studies, as noted, she had an iron sat of 19% with a ferritin of 439. In terms of her UA, she had 2 plus protein, but no blood by dipstick, no evidence of WBCs or RBCs per high power field. She had 5 Highland casts as well. She had a UPC, which was 0.5 grams per gram, and a UAC, which was 0.24 grams per gram. In terms of her serologic evaluation, she had a negative infectious workup, specifically with a negative RPR, HIV, hepatitis B antigen, and she also had a negative hepatitis C antibody. In terms of the rest of her workup, she had a free light chain kappa lambda ratio of 3.44. The serum immunofixation showed the monoclonal IgG kappa, and the urine immunofixation also showed the IgG kappa with the free kappa light chains. Of note, she was homozygous for G1 high-risk alleles in terms of her APOL1 evaluation. She did have a bone marrow biopsy performed as well, which showed kappa-restricted plasma cell clones detected on flow cytometry, and her skeletal survey was negative. She had a retroperitoneal ultrasound done as well, which was altogether normal without any signs of hydronephrosis, both kidneys being of normal size with normal echogenicity, and no cysts or other masses.
So, any questions for Steve?
What was the quantitative level of the kappa?
I believe it was 1.0 on the immunofixation itself. It's not written here, but her
1 gram per deciliter or per liter?
I believe it was 1 gram per deciliter.
Okay.
She had quantitative immunoglobulins done as well, and the IgG was elevated at like 2.9. The IgM was mildly elevated at almost 600, and then the IgA was normal. So the IgM and A weren't suppressed, decreased despite the IgG being elevated.
Anything else for our two Steves? It's the Steve and Steve show today.
So
one
one more question, Roger.
Yeah.
Was a urinary albumin to creatinine ratio performed?
Yes, it's there at 0.24 gram per gram.
Oh, okay.
About half the total.
About half. Okay, sorry, I missed it. Okay.
Yeah,
Were they calling this this clone in the bone marrow? Were they calling it lymphoma or myeloma? Were they calling it something, or they just said there's a clone?
Just said there was a clone.
So there's no increase in the amount of plasma cells or anything. It was just a clone.
Yeah, it was just restriction. Essentially, they were calling it an MGUS, to be honest with you, at this point.
Well, it's a clone. It's a clone defined by kappa restriction. So
yeah, that's right. But I mean, it wasn't. I guess let's put it this way: there wasn't enough there that they were willing to call it myeloma. I guess if that's what you're getting at.
Yeah.
So can I throw a piece of history here? As Steve pointed out, the finding of normal IgM and IgA is suggestive, per Dr. Kyle, of an MGUS. In addition, many years ago, Dr. Kyle, who was very creative, developed the thymidine labeling index to diagnose this entity. In other words, they did a bone marrow at Mayo, they isolated the plasma cells and they pulsed them with thymidine. And depending upon the uptake, in those days the cutoff was 15%, they were able to separate MGUS from myeloma. And interesting tool, no longer in use, piece of history. Thank you.
Thank you. I mean, I always find this whole myeloma thing kind of, I don't know, I don't want to use the word interesting again, but they've got these criteria, and I understand the purpose of criteria, but nature doesn't always work that way, and smoldering myeloma, for instance, it's kind of, to me, like a little bit pregnant and a little bit pre-diabetes and all this other stuff. I've never really liked that, but I do understand this disease can go on a long time. And I don't know if she's myeloma or whatever. It's just, it's kind of interesting that this is, to me, an MGUS is more, I don't know, it's probably a matter of semantics, but to me, an MGUS is No, never mind. I mean, obviously, I was going to say, if you have an MGUS, you're not going to have anything in your bone marrow. But I mean, obviously, if you have an MGUS, you do have something in your bone marrow. So, yeah, that was the smartest thing I've said.
Something
today.
has to be producing that protein, right?
Yeah. I think we'll
Well,
we'll have to cut that out.
She doesn't meet the criteria for myeloma or
Not even close.
smoldering myeloma.
No, that's right.
So
Yeah,
must
I mean-
have MGUS.
Yeah, not even close. Not even close. Right.
I mean, the interesting thing here is, 1% of patients under the age of 40 have a paraproteinemia. I mean, it's really uncommon.
Yeah.
I got to say, she was sent to heme because her hemoglobin was 10.5. And yeah, that's out of proportion to a creatinine of 1.1. But I don't know. Do you think everyone gets with a hemoglobin of 10.5 gets sent to heme for?
So that was the other interesting thing. We didn't send her.
Yeah.
GI saw her and said, well, there's no reason to scope her. Our thing was she's iron deficient. We couldn't explain it per se. And we thought maybe she's losing it slowly. And there's a GI, and they just kind of out of hand said, nope, it's not a GI problem. And they referred her to hematology. It's kind of like, how you back into stuff, and this got backed into basically.
Sometimes you back into stuff, and sometimes you open Pandora's box, and I think we'll kind of figure that out as we go through the case.
Yeah.
So we have a poll.
I guess you're going to ask a question but it would be nice if you kind of gave us a clue as to what led you to do the biopsy. What
I
was
can
it
answer
about
that
this
right out of
patient
hand.
that
She comes
do
back
a
with
kidney
this
biopsy?
paraprotein, and now we've got this young lady who's got renal disease with a paraproteinemia. And in all honesty, yes, we could have sat there and we just monitored it, but my feeling was we want to make sure we're not missing something now rather than later. That it's as simple as that.
Okay.
Did you ever do PLA2R on her?
No. Proteinuria wasn't really like I say, it was the paraproteinemia. I mean, this lady, after her renal function, because I've been following her since she was in the hospital, after she was discharged, she was on dialysis, as was pointed out there, for 40 days or so, and her renal function just continued to slowly get better. She had proteinuria, which I think was a result of basically her acute kidney injury resolving, and her renal, the urine protein just continued to get better and was down to what it was here, less than 500 milligram per gram. All of that was, everything else was getting better. Had it not been for this paraproteinemia, we would have probably just continued monitoring her, to be honest. So we didn't do a PLA2R at that time.
The reason I asked that question, I have a patient in my practice, which I think I presented to the group previously, and she had subnephrotic proteinuria, and her kidney biopsy did show membranous with Ig kappa restriction, but on her case, bone marrow was normal.
Okay.
Yeah, because that's we talked about that specific phenomena of restriction in membranous, which is kind of a different disease.
With PLA2R positive?
No.
PLA2 are negative, but that
Negative.
is
Oh, I'm sorry. I thought you said positive. Never mind.
no
I'm sorry.
negative. Sorry.
I'm
Let's
sorry.
move on. We've got a poll.
Yep.
So I want to know what people think. So what will this patient have? Mild global glomerular sclerosis and mild interstitial fibrosis, monoclonal gammopathy of renal significance, obesity-related glomerulopathy, hypertensive nephrosclerosis, and by that, I'm describing just shrunken, wrinkled glomeruli with maybe some afferent arterial or hyalinosis, and 5, lupus nephritis. This is a young woman. We don't have an ANA on, so that's always a possibility too. So put your vote in. It's anonymous.
While we're waiting for votes, there's a great question in the chat from Dr. Suki in terms of the uterine tissue. Did anyone look for amyloid as a part of the rupture? Was that ever looked at or sent to pathology? No.
No.
Okay.
I'm gonna try to see if I can find that right now. We're waiting for the poll to come back.
As we found with other pathology, unless they suspected it, that's not one of the routine stains they do on most. The only place we do it routinely is on renal biopsies.
Yeah. And who knows what, she presents kind of an emergency. Who's thinking about all that stuff? But yeah, it's a good point. All right, let's close the poll. we've got a 60% say a monoclonal gammopathy of renal significance. The second is ORG at 25%. 10% say some just mild global glomerular sclerosis, interstitial fibrosis. And we got a couple people that say just old-fashioned quote hypertension or lupus nephritis. So since this has such a oncologic onconephrology flair, I'm going to have our onconephrologist start the discussion. Dr. Gashty. Casey, what do you think's going on?
So I think your poll is a good starting point. So I do think there is probably going to be some monoclonal gammopathy related lesion in the kidney, but I'm going to talk about that in a little bit. But, just going through, this just kind of a very unfortunate lady who had this uterine rupture and hemorrhagic shock ATN. So unresolved ATN or partially resolved ATN with significant fibrosis left over, causing some degree of proteinuria, which is, I think, what your choice one is referring to is possible. I guess for that to be the case, we kind of need sequential measurements of her urine protein to see if she's always had the proteinuria or did that ATN completely resolve and now she's developed proteinuria. Either way, that's a possibility. So we can't rule that out until we get the biopsy. She was premature and she's obese. Both of those things can also cause secondary segmental scarring, and obesity-related glomerulopathy is one of them. So that's also a possibility. She's on losartan. She doesn't present with nephrotic syndrome. So that all goes along with a secondary form of that FSGS, maladaptive change. APOL1 is possible. Her blood pressure keeps, it's 130 on losartan. She's 34, I suppose. APOL1 is positive, although she's homozygous, right?
Yes.
So she is high risk for APOL1 nephropathy. So if that was her predisposition, a second hit could have been either the monoclonal or the ATN or the obesity. So there's definitely that milieu where she has multiple risk factors for developing a secondary form of FSGS. And then lupus nephritis. So 34-year-old African-American woman, always have to think about it. She had, let me see, what her lupus serologies,
There were none.
There weren't any. Okay. So, I would start there. ANA, double-stranded DNA, and complements would be very helpful, especially in somebody with subnephrotic proteinuria. A lupus membranous lesion would be possible. Even mesangial lupus could be possible. So I think lupus serologies should be checked, ideally prior to the biopsy. And then finally, this monoclonal gammopathy of renal significance. It seems like based on the ratio of her urine albumin to total protein, she has about 50%, which points towards possibility of a glomerular proteinuria. And of the glomerular lesions, immunoglobulin-related amyloid, monoclonal immunoglobulin deposition disease, immunotactoid, fibrillary GN, C3GN, and then pigment, which is the proliferative glomerulonephritis with monoclonal immunoglobulin deposition. I think C3GN and pigment are probably less likely. There's no hematuria. Her renal function seems okay for a proliferative lesion. So I am favoring some kind of a immunotactoid or fibrillary lesion, or an amyloid lesion. So some kind of a immunoglobulin-related glomerular deposition that's causing this degree of proteinuria, just because of the ratio of albumin to total protein. I suppose she could have tubular or vascular involvement as well. It's just that I think maybe putting too much weight on the albumin to protein ratio. So my number one is a MGRS with glomerular involvement and some kind of a fibril. And my number two would be, I really would like to know the lupus serologies. That's kind of a big category of a young African-American female with a uterine rupture. Why did that happen? And, was it amyloid? Does she have TMA? Does she have some atypical HUS? Something else that's causing some kind of a thrombus that led to this catastrophic rupture. And then obesity or premature related glomerulomegaly with subsequent proteinuria would be my number three.
Really, that's a nice discussion. I'd like to point out that Dr. Glassick has been asking for birth weight and prematurity for the last 3 years. Been way ahead of the curve. This may be the first time that we had an answer for him.
We finally had it in there.
Yeah, we finally had it in there. So Dick, we're working on it for you. I know it's one of your favorites. It's not. It's totally relevant. So, just can you go back to the poll for a second? Actually, Casey brought up a good point, but one of the reasons I put number 1 in there is I thought that, anytime I see any catastrophic event in a pregnant woman, I always worry about cortical necrosis. And, she had bad renal failure and a lot of stuff goes on. And I thought, well, maybe if she had cortical necrosis, that what the residual that might be what I described in number 1, but probably more likely is totally fitting is what you said. Even ATN, you could see that, but that was kind of the point of number 1 for me.
But with cortical necrosis, and Dr. Glassick can kind of speak to this definitely more than I can. My impression was when you have diffuse cortical necrosis, you don't get better.
Well, you do get actually that. I mean, if I can, I'm going to butt in. I'm sorry, Dick, but I'm going to butt in because that was one of Barry Brenner's first models of human models of renal reduction in renal mass. One of his best models of a 5/6 nephrectomy was cortical necrosis in pregnant women that would they'd be on dialysis, they'd be on uric, and they'd get better off. A lot of them would get better. It's not complete cortical necrosis because it's patchy. So they get better, but what they probably don't end up with is a creatinine of 1. They end up with a creatinine of 2, and then over the time they develop progressive renal failure without any other insult. Kind of like a single severe insult reduction in renal mass. So, I think 1 would be unusual, but they can get better. Dick, do you have anything to add to that?
Well, I think you've stressed the point that renal cortical necrosis is a spectrum. I mean, all the way from total, which is irreversible, to mild to moderate patchy disease. And a pregnant woman who has massive hemorrhage in the later phases of pregnancy is certainly a high-risk patient for patchy renal cortical necrosis. And I have seen patients return to a serum creatinine within the normal range.
Mm-hmm.
That doesn't mean that she hasn't lost a substantial amount of nephrons. And that means that the residual nephrons that she does have are undergoing massive compensatory hypertrophy, which is aggravated by her diabetes. And if I had to put this together as a single overarching, she had patchy cortical necrosis from which she recovered. In the presence of obesity, she has massive compensatory hyperfiltration and has now begun to develop proteinuria as a consequence of that, and the MGUS is completely coincidental.
Bill, what do you think?
That's why the biopsy was done.
Of course. Bill, what do you think's going on?
I was gonna kind of take the opposite route of Dr. Gashi with 1 and 2 and flip it just as Dr. Glassick had said. I think she's got APOL1 high risk alleles to start with. She's got a low birth weight, goes through this horrific ATN or maybe even vascular compromise leading her on dialysis, and then there's going to be subsequent scarring from that. So we might see sort of this classic maybe APOL1 global sclerosis. There'll be some focal sclerosis in there. I'm not sure if it's going to be huge glomerulomegaly or not, but I think it's going to mostly just be very scarred. And that global sclerosis and focal sclerosis will be enough to give her some albuminuria. And she's also going to have some pretty significant tubular disease, despite her creatinine being 1. So I think she will have a lot of nephron loss. I do not think that this is going to show anything of a monoclonal gammopathy of renal significance.
Great. Dr. Kramer, I think you're on. Holly, you have any thoughts? And if you're still here, you can unmute yourself and tell us what you think's going on.
Yeah, I agree with Bill. I think anyone born before 30 weeks is going to have a low nephron mass, and then tie that up with obesity, and she also obviously is going to lose nephrons when she had this horrible AKI episode. So I'm really impressed that she only has a creatinine of 1 at this time. And I just wonder if anyone had done a cystatin C, because maybe she has really low muscle mass, maybe she's really inactive, and maybe look at that, use a cystatin C in this patient. So I was on the obesity glomerulopathy, and that the patient probably, the MGUS would be a bystander, but I'm can be proved wrong.
That's why we do the biopsy, which we always say. Anybody else have any thoughts? Mario?
How do we explain a bicarbonate or 21? Could it be some sort of renal tubular acidosis, and we are dealing with some other diseases such as Sjogren or even proximal crystallopathy type of thing? Just to add to the thought, but I still think it is related to her previous insult that happened many years ago, and she is left with some residual kidney disease.
I mean, it's possible. I mean, these are send-outs, so it goes to wherever the lab is at, and you know, there are nice papers that show that if you were to do the bicarb here right now and then you send it out, it's going to be a few milliequivalents per liter lower. So it's possible she has an RTA post all of the things that have happened to her. It's also possible that this is just part of the function of having it be a send-out lab, and the CO2 is just a little lower as a result of that. But it's a good possibility.
I have to recognize Holly's background is Michael Jordan. I think you get the background award for biopsy conference. We got to step up our game. That's fantastic.
I don't think it's Jordan. It
not
starts with a
Jordan.
3.
I can't say who is it.
No, that's Trey Brown. He's he's a Loyola basketball player.
Oh,
Okay.
go figure. I tried. Okay, we're going to spin the wheel, see who reads the biopsy.
Still Chicago-based basketball. That's the point.
There you go. They're still trying.
I'm colorblind, but their jersey did look like a Bull jersey. Saba. Saba, you here?
Yeah, she is.
Right.
Give me a second, Saba. I will.
Saba's one of our second-year fellows. She was dying to read this case. I know that the wheel hasn't picked her for at least a week, and she's been feeling left out.
Go ahead, Saba. Unmute yourself.
Okay, can you hear me?
Yep. Give me 1 second. I'll give you control number.
Perfect.
Flag sometimes. Let's see here. Go ahead and click. Yep, you're controlling the screen.
Okay. All right, so this is our trichrome stain. We have one core that looks pretty nice here. I'm looking for the, I guess, fibrosis, the blue staining material, and there's some, maybe like 15 to 20%, I would say. And then I see a few glomeruli, but we'll comment on them a little later. And then the tubules, for the most part, look nicely laid, like back to back.
David, how much fibrosis did you say?
Yeah, 20%.
Oh, okay.
All right, so this is our H&E stain. We have one glomerulus here in the middle. I don't really see too much mesangial expansion throughout here, but I can comment on that later. And then there's maybe some hypercellularity here, but
How about the size? Does it look normal or enlarged?
I would say it looks enlarged. It's taking
Yeah.
up most of the screen, so maybe some glomerulomegaly.
Yep, there is.
And then a few dysmorphic RBCs here.
Oh, those are just unliced red cells.
Oh, unliced,
Yeah.
okay. And then
There's a large artery there to the right.
this.
Yeah, there it is. Yeah.
It doesn't look too, I guess, thickened to me.
Yeah, maybe mild arterial sclerosis. Okay, so far glomerulomegaly.
Mm-hmm. So this looks like PAS stain. I see what looks like, I guess, part of a glomerulus right here, and there is some segmental sclerosis that sticks out. Again, no significant mesangial expansion that I can see. The capillary loops look nice and open, and I don't really see any hypercellularity, but this is kind of sticking out.
Yep, I agree. Yep, segmental scar.
And David, on that, if you in terms of the intensity of the PAS stain, it's pretty similar to the basement membrane, right? Because I know amyloid and stuff was on our differential, although it'd be a little more nodular, but that's pretty nicely stained.
Yeah, it's normal intensity.
Yeah.
Yeah.
It's not weak. It's not
certainly
weak.
not. Yeah, certainly not weak. Yeah, exactly.
Okay, we have another PAS stain here. Again, this looks like this could be segmental scar formation here. And then is this around like that? Would this be called like parahilar near the hilum? Where it's located?
That's good. I can't quite tell where the hilum is in this one, but keep that in mind on the next image. Yep.
Dr. Whittier said fractured cast. It kind of does look like that.
I think that's the microtome. The whole thing is fractured.
Yeah, that's what I was kind of joking. I think we need to sharpen our knives.
Well, there's a financial cutback over in pathology.
Yeah. We're using knives from 3 years ago.
Yeah, I think these are some of Mel's old knives that they just brought back into.
All right, so we have another H&E stain here.
So yeah, so 2 gloms, 1 globally sclerosed right there. There you go. Yeah.
Okay. And is this another one?
Yeah, so go down a little bit to the left and you can see where the afferent arterial is. And to the right, yeah, and to the right a little bit. That opening, yeah.
I see.
Right at the bottom of the arrow.
Okay.
Keep going down.
Yeah.
Right
There you
there.
go.
Right there.
Yeah.
Okay. Okay, so this would be parahilar then.
Yeah.
Okay.
Yeah, so all off to the left of that's all perihilar segmental scar. Yeah.
Okay.
I mean, most of that glomerulus is scarred. It's, I suppose, to me, that's almost globally sclerotic, but I guess the top has some normal, so.
Yeah, the right half still functioning.
Okay, so this is our Jones stain or silver stain. Again, looks like a pretty big glomerulus. It's taking up more than the screen is. And I don't really see any spikes or holes that I'm looking for. The capillary loops look nice and closed or open. I don't
I agree.
Here. So for immunofluorescence, IgG kappa and lambda are negative. So this is it's the toluidine stain. Blue stain.
So this will be our EM sample. And then, do you see a glom there? That we
I see one here. And is this like scarring?
Yeah, another segmental scar there in that glom for EM.
Which is perihilar again, right?
Yeah.
I mean, there you can pretty much see the vascular pole.
Okay. It is FSGS related to birth weight. Oh, sorry.
Okay.
Okay, yeah, so now we'll look at a couple EM pictures. I think I included some low power ones looking at foot process effacement, which is always important.
Okay, yeah, so looking around, maybe a little bit of foot process effacement here. Otherwise the podocytes look pretty good and intact to me.
Yep.
Maybe you can give you a little higher power. This is, well, maybe not.
Again, maybe right around here, some effacement. Otherwise it looks okay.
Yeah, very focal effacement. In the most part, they're well preserved, the foot processes.
And what'd you estimate, David?
20 to 30%.
Yeah.
Seba, what are you going to call this?
So since it was not global foot process effacement, I would say this is like a secondary FSGS pattern of injury, maybe from the obesity.
Well,
Was
what
it-
else did you see?
What else did we see?
You described it right off the get-go. The size of the glomeruli.
Oh, and glomerulomegaly. Glomerulomegaly.
Was there evidence for a monoclonal gammopathy in the kidney?
No.
Okay, I'm
And
gonna.
Congo red was negative. I mean, I don't know that it was said, but it was negative.
So I'm going to go to the next poll.
Can I ask David a couple of questions?
Yes, of course.
So I recently inquired about calling glomerulomegaly what we just saw. That is a glomerulus that impresses to be big, a glomerulus that occupies most of the Bowman space. And I was told by an expert in renal pathology, aside from David, that the glomerulus must be measured to really call it glomerulomegaly. And
All right, was this Agnes again, or who are we talking about?
we're talking about Helmut Rank,
Okay,
that it must be measured, otherwise you introduce fallacies.
No, Mario, it doesn't have to be measured. I mean,
Well, again, renal pathologists lack consensus. I mean, what can I say?
yeah.
I mean, I'm bringing it up for discussion. You say no, he says yes. I mean,
So to Tony Chang at University of Chicago, he doesn't measure them. Other renal pathologists in the community, I've spoken to others. Few have the ability to measure the size of a glomerulus.
all right.
So let's be honest, because I mean, we used to be able to measure these, and whether it was necessary or not, Steve's smiling, but I think Dr. Schwartz had a tool, right? And he would be able to.
yeah, Dr. Schwartz had a tool, but he had a measuring tool, and we have not been able to. I don't know what happened to it, where it went, but it's gone, and we've not been able to get a new tool. But yes, we were able to do it in the past. Mel actually acquired it so we could measure it after I forget if it was after Bavette's paper came out, where the threshold, I think the break point was like 250 was anything above that was considered glomerulomegaly, whereas normal glomeruli were somewhere around 150 or so, the 200. But we just haven't been able to. But even before that, Mel would do it, by just what Dave was describing. If it filled at a certain power, if it filled the entire slide, that was good enough. And I will defer to David and the other pathologists. But yes, it would be ideal if we had that.
I think also there's a point here that if you're doing a study on glomerulomegaly, it would certainly be important.
Well, I think
I'm not sure clinically that relevant. It's the same thing with like measuring podocyte effacement. I mean, David painstakingly did that for one of our podocytopathies and membranous lupus nephritis because we needed the number because we were seeing if it was for the study, if it was statistically significant. But you can tell what diffuse foot process effacement is, and I think you can tell what glomerulomegaly is. But I think if we were going to publish something on it, we would need to measure it.
But you're right,
In other
Mario. I
words,
mean, it would be
there is
ideal.
the Chicago way and there is the Boston way. And, I mean, I think it remains to be seen. The other thing is interstitial fibrosis. We keep calling, oh, what do you think? 10%, 20, 30? I mean, again, I think that particular area of histology is open for grabs. I mean, there are individuals such as Bob Colvin from MGH, as well as one of his former fellows, I apologize, I don't remember the name, he works at Emory, who have been working in this area for several years, and they are yet to come up with a reproducible way that, renal pathologists will agree on the percentage. So it's fairly subjective, I would say, unless it's all blue. So anyway.
No, you're right. I mean, all these things are subjective, and even Agnes Fogo shows that if you section these paraffin blocks and keep sectioning through, you'll find more segmental scars than if you look at one or two sections. I mean, so the more precise you can be, obviously, the more ideal it is. But I mean, this is kind of the world we're working in right now, and while it would be ideal to have something to measure it by, and as Bill says, and as you're alluding to, Mario, you know, you have to have something to measure it with if you're going to do a study. And I agree, you know, I'm sure Helmut has all kinds of tools, and it would be ideal, but you know, in an unperfect world, we have to use what we have. And
I like to
best
make a
we've got.
point. You know, there's so much subjectivity to this that when Dr. Lewis and the collaborative study group set up the collaborative study group trial, Steve, correct me if I'm wrong, but they had 3 pathologists independently read 4 pathologists. Yeah, Steve, go ahead.
No, there were 4.
Yeah.
There were 4 different pathologists: Gary Hill, Keith Holly, and Jay Bernstein, along with Mel Schwartz, were all had to look at the biopsy and basically say that it was consistent with 3 greater than 50%, or what we would call 4 at the time. So yeah, they all 3 had, and actually they published, I think, papers showing what their consistency was as far as agreement goes. But yes, there's a lot of subjectivity. There's no question about it.
Yeah. So we always strive for more precision. But I do remember that the poor man's measurement is if it fills the screen, then it's probably big. And I think they looked a little bit big. So let's go on to our second poll. You probably saw it. So yes, Dick.
Well, I'll wait until you finish this poll.
Okay.
Then I'll come back.
So what do you think? This patient still needs pronase digestion.
No.
We've got a monoclonal in the blood. We've got a monoclonal clone in the marrow that corresponds to the monoclonal in the blood. We've got a negative IgG, kappa, and lambda.
But Roger,
Yes, sir.
look at the EM.
Well, there's nothing there. I agree.
That's right. There's nothing there, not a single deposit.
And Roger, I think your rule was when in question, pronase digestion.
That's not my rule. That's my catchphrase.
And I love that catchphrase. And
I think this is
I'm not sure there's much in question here.
This is going to get interesting. I love this.
Good. I'm glad.
If you don't see electron dense deposits on the EM, I don't think pronase is going to do anything.
All right, we have Dr. Glassick in this corner, and we have Dr. Rodby who went out on a limb in the other. Let's see how.
Listen. I'm not voting here. We just had the opportunity to give my quote. I don't know. I didn't say there was a question. So anyway,
so
the
Dick,
voting was 2-1.
I think the answer is, so Dick, your feeling is there's no reason to do it at this point, right?
Not with that electron microscopy.
Okay.
I agree.
Casey, what do you think?
Bill.
I'm not going to go against Dr. Glassick.
And now Steve's holding this back, and he's gonna prove us all wrong.
No. Can I go on, Roger? Or
Yeah, please, Steve.
So I actually want to see you squirm a little bit, but I guess I'll take you.
It
So we
happens
asked
all
for
the
it to be
time.
we asked for it to be done just because of the paraproteinemia, and our pathologist said there's no indication. So Dick, he agreed with you. He felt there was no reason for the additional cost of doing pronase digestion, and so it wasn't done. And then he sent me the paper by Nasser et al., which shows the criteria which are listed here, which again, David felt that this biopsy didn't qualify for that. And so he agreed, he agrees with you, Dick, and we didn't do it.
I also reached out to Nasser, and he agreed that it shouldn't be done. It's not indicated in this case.
Yeah, well, it's his paper. Of course he's
Yeah.
going to agree with you. Steve, you can continue.
Go ahead and click on the screen. I'll give you control here.
Oh, so.
Yep.
All right. So I don't know, I don't know that we'll ever know what really has caused this lady's lesion. And we talk about this constantly. I just put together a few slides because I found this whole thing very interesting. We've talked about the pathogenic classification of FSGS and all the various things that could cause it. It's just, as we've always talked about, it's just describing a lesion. It doesn't tell us what caused it. And this woman has a number of reasons, right? Unresolved acute kidney injury, which leads to hyperfiltration, obesity related, premature low birth weight. Apparently she was in the hospital for 6 months after she was born to get nutrition. She apparently weighed about 1 kilo. So she was clearly low birth weight and premature. And then the whole issue is, how does ApoL1 play into this? For me, these are all kind of interesting aspects of this particular case.
But there is a difference, Steve, between what you and I generally regard as ATN and renal cortical necrosis. And ATN glomeruli are not destroyed.
No, that's
Glomeruli
right.
remain intact. However, in renal cortical necrosis, glomeruli are also destroyed.
Yep, no, that's right.
So the nephron number in a patient who has recovered from AKI, also known as ATN, should have a normal glomerular number for the age of the patient. However, a patient who has recovered from patchy cortical necrosis will always have a reduced glomerular number relative to the age.
No, that's a good point. And her global sclerotic glomeruli were a third of her biopsy. I don't think we actually brought that up, but when you did a glomerular count and how many were globally sclerotic and how many segmental sclerotic glomeruli, 27% of her gloms were globally sclerosed and 15% were segmentally sclerosed. So, and then she had what, 20% or so interstitial fibrosis. So I don't know if that's what you're alluding to, but she's only 34 years old. And I think to have a third of your glomeruli already being gone is a little in excess of what we'd expect for her age. I mean,
yeah, unfortunately, it's impossible to enumerate the number of nephrons remaining by counting glomeruli in a kidney biopsy.
Understood.
That's been shown over and over again because some glomeruli just disappear completely.
Understood.
They are
But this
reabsorbed.
This is the best we have, though, right?
Yeah, but yes.
But I think I mean, both Holly and Dick made the point that this, there's probably a lot worse than a creatinine looks like. And I think that's a good, that's.
Well, it also shows you that how well the kidney can compensate. I mean, here she's got.
Exactly, which is thought to be, at least the Brenner hypothesis was that kind of a hyperfiltration injury, that was kind of the whole thing. So
yeah,
that's
barotrauma. Yeah. So we've thrown this up before. I think it's an interesting, review, primary genetic and maladaptive causes of FSGS. With the maladaptive, oftentimes not always being perihilar and having glomerulomegaly with focal effacement, which is similar to what we saw in this lady. Again, whether that's whether she has secondary FSGS or not, I think she does. It's just a matter of what's caused it. Babette Degatti some years ago looked at low birth weight, secondary FSGS, the reduced nephron number, increased glomerular volume. There were only 6 patients. They were 32, but they were born not unlike this lady at 22 to 30 weeks. And unlike this lady, they were about 1 kilo. Here's their renal function. Interestingly, the albumins were normal. They were anywhere from 1.3 to 6 grams. None had nephrotic syndrome. And again, they had glomerulomegaly, focal sclerosis, and partial foot process effacement, not unlike we saw here. And then there was a paper recently, 2013, which found that they were basically measured the number of podocytes in patients that had low birth weight FSGS versus normal birth weight. And they found that there was so-called podocytopenia. That's an easy one to say. Podocytopenia. I thought Eberhard Kritz, or not Eberhard Kritz, but Dr. Kritz years ago talked about this and how this may predispose to, segmental scar and, being perihilar, if you will. But again, they were showing that there were a reduced number of podocytes in these particular babies that were of low birth weight and premature, which again may be a predisposing factor. Then flash to the obesity-related glomerulopathy, which we've alluded to, that Dr. Degatti made relatively popular in 2001, which also it seems to exist in this lady. Her BMI was almost 50, and I can tell you that her BMI, I was able to find records back to 2019 and not much beyond that, but her BMI in 2019 was basically 48 as well. It's interesting that most of these patients are white. In this case, that she wasn't. She wasn't nephrotic, not unlike what was seen in Babette's paper. Glomerulomegaly, and almost every one of them had perihilar lesions, which was interesting, with partial effacement, not unlike Our Lady. Compared to patients with idiopathic FSGS, these patients have those with obesity-related glomerulopathy have a more indolent course. And as we know, you don't treat with immunosuppression, you treat with weight loss, ACEs and ARBs, etc. Conservative management, if you will. And then we get into the ApoL1, which is the thing that I continue to find interesting. This was an editorial that COP did for a paper that I'll show you in a minute, showing that if you have two high-risk alleles, you know, in the US, you're about 27 times as likely to get HIV, HIVAN. If you're in South Africa, almost 90 times as likely to get it. You're 17 more times likely to have FSGS if you have the APOL1 high-risk alleles, hypertensive kidney disease, and so on and so forth. And with membranous, it's been associated with a faster progression. Also associated, though, with twice as likely to have AKI. This paper, many of you may have seen. I just found it fascinating. This was out of Columbia Presbyterian, a large number of patients that basically they looked at, I think almost 1,100 had low risk genotype, and then about 250 had high risk APOL1 genotypes. And what they found was, here's two APOL1 high risk alleles and only one. And this looks at FSGS, hypertension, C3GN, et cetera. What was interesting was that we usually talk about only one being heterozygous is not basically causing a higher risk, but in FSGS, even the ones that were heterozygous seem to have a higher risk of developing FSGS than if they were just, you know, high risk per se with two high risk alleles. So even one high risk allele, even being heterozygous, could portend an African American to be at higher risk of developing FSGS. The other thing I thought was very interesting about this paper, because I hadn't seen it before, is they actually looked at the rate of progression. And these patients all had chronic kidney disease. So here was high risk patients, low risk. Low risk were either heterozygous or, you know, no high risk alleles. And I forget, there were only about 150 or so, I believe, that were heterozygous. But what they found was they actually, for the first time, at least that I'm aware of, showed that if you have G1 versus G2, these patients seem to do worse. And if you look at their, I think maybe if you carry it over and you look at their rate of loss of renal function, it's 8 ml per minute per 1.73 meters squared per year versus 4.82 milliliter per minute per 1.73 meters squared per year. So these patients progress at almost twice the rate. And then if they're, you know, it was G1, G2, it's somewhere in between. And then these low risk patients, again, were patients with CKD that either had polycystic kidney disease or congenital abnormalities of the kidney that were either zero, it had two wild types, or were heterozygous. Their average loss was 3.6 milliliter per minute per year. It's the first time I've actually seen that there was a difference between the high risk allele and the progression of renal disease. They also actually suggested that they found, and they didn't report the information, that the heterozygous patients had a higher rate of loss of renal function as opposed to patients with two wild type. And that was the first time I'd ever seen that. I mean, usually we think of heterozygous patients as being low risk, but they suggested, at least in their study, that they may be at higher risk. So, you know, this lady has, you know, prematurity, obesity, had acute kidney injury with probably some scarring left over with glomeruli with hyperfiltration. She has a number of risk factors that put her at risk of progression, which I just find interesting. And whether those things played into her acute kidney injury initially, I kind of doubt it. I think anybody that goes into shock like that and has a cardiac arrest is going to go into acute renal failure. But I think going forward, she has a lot of strikes against her that we need to be, you know, aware of and try and manage her as well as we can. And she's already on an ARB. Whether we should put her on an SGLT2 inhibitor, I guess, is something that could be discussed. Weight loss would definitely be of value, I think, in her for sure, given her obesity. And I'll leave it at that.
She doesn't have much proteinuria, but she's on a very low dose of losartan. I mean, I think I'd probably crank that up. I mean, we're all thinking about big glomeruli hyperfiltration from whether it's ORG, whether it's small birth weight, whether it's residual cortical necrosis.
Yep.
I mean, that's something you could do.
Yep.
And even, you know, I don't know what her risk is going to be. Her blood pressure is not that bad on a single agent. She's pretty young, 34. So she's got a lot of life left of renal hyperperfusion. So You know, it is possible to think about ramping that up, and I know a lot of people would just put her on a SGLT2 inhibitor as well.
And I think there's a study of APOL1 high-risk alleles right now, right? But I think there's a proteinuria cutoff of 700 milligrams or something.
I mean, it has to be 700, Bill?
I think it's above 700 is where they want to study. She might fit into that.
What
study.
about,
Well, you might, I mean, if you believe that APOL1 nephropathy is playing a role in her renal pathology and her proteinuria, then, you know, she should be a candidate for the experimental drug that sixagliptin, or sixagliptin, I forgot how exactly it's spelled. It was published as a pilot study in the New England Journal about 6 months ago with positive effect on proteinuria, no long-term observation, but it's specifically designed to reduce the adverse effect of the APOL1 gene expression in podocytes.
Now,
I don't happen to think this patient has APOL1 nephropathy. For the simple reason is that hypertrophy is not a manifestation of APOL1 nephropathy. That's a manifestation of reduced nephron number, either from birth or from a consequence of nephron loss during patchy or cortical necrosis, or perhaps due to the effects of obesity.
Yeah, I actually reached out to Barry Friedman to see if there were any studies on APOL1 in patients with low birth weight and FSGS, and he wasn't aware of anything.
Yeah.
What about taking a hard line on weight loss?
Well, I think irrespective, I think that's, you know, we've talked about that. I think that's something she needs to really pursue. I mean, for all kinds of reasons we all know about. I mean, she's 40, she's got a BMI of 48. I mean, it's almost 50. You know, it's I think in her best interest overall to try and lose weight and get that down.
Yeah, but wasn't one of the GLP studies stopped early because it had some renal protection? I think that might have been only in diabetics, though. Is that Pravir? You're not nodding your head. Was that only in diabetics?
I believe that was only diabetics. I'll have to look it up, but I think that was only diabetics.
I mean, that's maybe the next, one more drug in our armamentarium. And then if it was only diabetics, I doubt it'll be only diabetics because where it's effective.
Roger, you raised the SGLT2 story. How many people in the audience would start this person on SGLT2 inhibitors now?
Not now, with losartan.
How about a GLP-1 agonist?
Absolutely a GLP-1 agonist.
Yes, for weight loss, yeah.
Absolutely.
Absolutely.
I need to buy the medication, gentlemen? No. So unless that changes in this country, it's not going to happen.
Say again, Mario.
I mean, I just think that one thing is what we want, what science wants, and another is reality. Patients cannot afford these medications.
Yeah.
At any rate, the other thing I wanted to point out is that not all patients with APOL1 genotype homozygous develop kidney disease.
Yeah, that's right.
Oh, that's right.
There is a sizable percentage, depending upon who you read.
Well, I mean, what is it in the African American population in this country? It's something like 15% have high risk alleles, and from what I saw, it's about 15% or 20% of that actually go on to develop kidney disease.
That's right.
Yeah.
And I posted a paper interesting from Chris Larson, where he indicates that there are 3 findings on a biopsy which are suggestive of APOL1 mediated kidney disease, and they are Dr. Glassock's favorite, a solidified glomerular sclerosis, large tubules with the cystic structure, and thyroidization of the tubules. And interestingly, I have heard the same study recently from the group at Columbia, the pathology department there. So if you find those changes, I think it's worthwhile thinking about the possibility of APOL1 mediated kidney disease.
I think my colleague, Dr. Rulan Paruk, will think this probably has a APOL1 component to her disease. And she actually discussed on our last rounds, if Dr. Rodby remembers that, it was an eloquent review on that, and it is on YouTube if you want to see it.
As an aside, for Wegovy, which is the drug that's approved, I guess, for weight loss, it's almost $1,500 a month.
Yeah.
There are patients getting it. I've had patients get it, so it's
No,
not out of the,
it's a good idea.
it's
a
not
good
out of the
idea.
question. And I think that, these are, I don't know, I'm going to exaggerate, miracle drugs in a way. And I have a feeling that there's going to be a way that they will be available to the public.
But it seems, isn't there something more recently? I don't know if there was psych issues related to this now that are starting to surface.
Yeah, there was something about that. You're right. But it never, it was mentioned somewhere in the newspaper, actually. Whether it was really a study drug or not, I don't know. But there were some issues because patient brought to our attention. It's easier to get in Canada, except we are on backlog because we have been using so much for weight loss, but it was not that difficult for us to get this drug.
Interesting. No, that's a good idea. I mean, for sure, we need to push the losartan up. I mean, that's the easy thing to do.
There's also, I read some lawsuits regarding gastrointestinal paralysis, basically. Coming out of Louisiana. They're trying to make it a class action.
Great.
As a result of a GLP?
Yeah.
And actually along those lines, and I'm glad he brought it up, is patients on those drugs are advised when they go for surgery to withhold the medication for at least 12 hours because of the concern with aspiration.
Huh.
Interesting.
I don't want to raise something that I can't really discuss with any degree of expertise, but there's been a recent seminar showing that a ketogenic diet is nature's way of giving a GLP-1 agonist.
Oh my goodness.
Very interesting data from Santa Barbara. A guru of keto diets has accumulated a fair amount of observational data that suggests that a keto diet does basically the same thing to the kidney as a GLP-1 agonist.
Roger,
and of course, it's a lot cheaper.
I'm pretty much every other month I'm trying to get ketotic. So yeah.
Not that Roger needs to lose any more weight, for God's sakes. But
well,
yeah.
that's for another time. But
Okay.
but you look at this. You look at this woman and how many hits can this poor woman have? I mean, she's low birth weight. She's ApoL1. She's had a major renal catastrophe with her very possible cortical necrosis
and she lost a child. I mean, how much more can it take?
Yeah, it's really very, very unfortunate. And hopefully she'll do okay. And hopefully we understand more about this so we can, change her trajectory. Of course, we don't know what her trajectory is, but kind of the feeling is here that she may not have a good future. So, to do whatever we can to nip this in the bud. Anybody else? Otherwise, I'll wrap it up. I do want to remind everybody, Hanukkah starts tomorrow. I wish you a happy Hanukkah.
Happy Hanukkah, everybody.
Peace for everybody, and let's get some peace in the world. And we'll be in touch about next week. Thank you, everybody. Great discussion, everybody.